Thank you all for joining this session. My name is Aarti Darra. I'm working as a bioinformatician at Carkinos Healthcare Private Limited. In this presentation on genomic testing in oncology, we will be covering the basic introduction to genomic testing, the guidelines for eligibility for testing, and finally, we will be talking about tumor agnostic markers. And in this presentation, we will be covering three: tumor mutation burden, microsatellite instability, and homologous recombination deficiency. So before I start this presentation, let me start with some stating some overarching facts regarding the clinical actionability in oncology. Between 2017 and 2022, there has been an almost fourfold increase in the fraction of the tumors harboring a predictive biomarker, which is a remarkable jump. And this can be appreciated more by the fact that the tumors carrying non actionable drivers have almost reduced to half. Not just that, around 17% of solid tumors qualify for HRD positivity, implying that they are the suitable candidates for PARP inhibitors. And in certain cancers where tumor only testing comes negative, the diagnostic utility of germline testing can be expanded and the clinical actionability can be generated if in case there is a pathogenic germline variant. So in this era of precision medicine, the capacity of genomic testing is not just only restricted to finding the actionable targets, but also for digging out the resistance markers, which would indicate which therapy is not likely to work in certain patients. And not just that, along with these genomic alterations which are found in the individual genes, the genomic signatures can also provide a suitable option for treatment in a tumor agnostic manner. And lastly, by investigating the pharmacogenomic profile, one can come up with the right drug and the right dosage for the patients. So, when we talk about cancer, cancer is generally driven by changes in the DNA. These changes in the DNA could be germline in nature or somatic in nature. When we talk about germline variations, these variations are inherited from parents and are present throughout the body and can be passed on to the next generation. On the contrary, the somatic variations they generate through the lifetime in non-gamete cells and are not inheritable in nature. And these genomic alterations can be studied through next generation sequencing, which provides a set of deep sequencing systems to sequence the genome in either a targeted manner, which could be whole exome sequencing or targeted panels, or an untargeted approach like whole genome sequencing. Whole genome sequencing can almost detect all kinds of genomic variants and does not require a pre-capture step, whereas the targeted approach where whole exome sequencing and targeted panels would require a pre-capture step to amplify the genomic areas of interest, and they usually cover around 1 to 2% or 0.1% of the genome respectively. So now, since there has been various advancements in cancer genetics, not just in terms of the reduced cost and the improved stats in NGS, but also in advances in the bioinformatics workflow, and also the enriched mutation databases have almost streamlined the major workflows in cancer genetics. And one of the uh, landmarking milestone has been the use of multi-gene panels, which can detect genomic variations as well as genomic signatures in one go. So, given the fact that we have so much of information when it comes to clinical actionability, the time is to navigate and apply this new information in patient care through genetic testing. So, when we talk about genetic testing, the workflow starts with procurement of a suitable sample. It could be a blood sample for germline testing or a tissue biopsy for a somatic testing. And then, DNA is isolated, and based upon the NGS assay, accordingly a library prep is performed, followed by sequencing, and in at last we obtain the data in form of number of variants that belong to that sample. Now these variants number could be in thousands or in millions depending upon the NGS assay, and thankfully we now have the guidelines for interpreting the sequence variants like ACMG, AMP, ASCO, and CAP. Using these guidelines, the pool of variants, which was in the number of thousands to millions, can now be narrowed down to the actionable targets, and accordingly, targeted therapy can be given. So, a little bit about targeted therapies. The first successful targeted therapy dates back to 1970s, where tamoxifen was approved for treatment of HER2 positive breast cancer. Followed by that, in 1998, trastuzumab was approved for HER2 positive breast cancer, and with the discovery of Philadelphia chromosome, the development of imatinib marked the beginning of the targeted therapy. And by 2021, we had 115 new approvals for novel biomarkers. And this slide will give you a basic glimpse of the targeted therapies that have been FDA approved. Now, for who should test for getting these kinds of targeted therapies? There have been certain guidelines which have been laid down for it. So, patients with metastatic or advanced cancer should undergo genomic sequencing in a certified laboratory if the presence of one or more specific genomic alterations has regulatory approval as biomarkers to guide the use of or exclusion from certain treatments for their disease. So recently, European Society of Molecular Oncology has updated its guidelines in 2024, according to which there have been recommendations for specific cancers. So let's talk about one by one. For advanced non-small cell lung cancer, it is recommended to perform tumor NGS profiling using multi-gene panels. For advanced breast cancer, tumor NGS with hormone receptor positive or HER2 negative should be performed as standard of care. And after resistance to endocrine therapy, NGS testing should optimize the likelihood of detecting ESR1 mutation. Additionally, patients with increased likelihood of germline BRCA1 and BRCA2 mutation should undergo a clinical genetic testing even if negative on tumor NGS report. For the other two cancer, advanced colorectal cancer and advanced prostate cancer, multigene tumor NGS profiling is recommended. And ESMO guidelines also encompass advanced pancreatic ductal adenocarcinoma, where tumor NGS is recommended, and it should be noted that NRG1 fusions are a part of panel because PARP inhibitors and NRG inhibitors are now a part of clinical trials. Next, for advanced ovarian cancer, tumor NGS for patients with advanced high grade ovarian cancer combined with a HRD signature, which we will be talking about. And if DNA quality is suboptimal and or in case of family history or no detectable tumor BRCA1 and 2 mutation, they should undergo germline testing. Now, having said about the somatic testing, there is a one of the technical limitation associated with somatic testing, which is that it could miss 10% of pathogenic germline variants, implying that some patients could miss treatment opportunities. And to take care of that, germline testing should be expanded to negative tumor only report and also additionally to rare tumor types. Now, the reason behind extending germline testing is that because uh, of the diagnostic yield of germline testing. For example, in breast cancer, around 11% of the samples would have one or more pathogenic germline variants, which, if not performed, could be missed due to somatic testing. And due to this, NCCN has now updated its guidelines to endorse germline testing for a wider population, which includes all patients with ovarian, pancreatic, metastatic prostate, and metastatic breast cancer. So now let's talk about the multi-marker testing, wherein we will be talking about three biomarkers, TMB, MSI, and HRD. Multi-marker testing is an essential approach to stratify the population. Some patients could have genomic alterations which can be treated using targeted therapy. Others could show the others could have genomic signatures like they could be MMR deficient, they could have high TMB, they could be HRD deficient, and each of these approach would go for a particular therapy. For example, for MMR deficiency and for high TMB, these patients qualify for immune checkpoint inhibitors, while the patients that show HRD deficiency, they qualify for PARP inhibitors. So let's start with tumor mutation burden. It is usually defined as the number of somatic mutations and is generally expressed as mutations per megabase. So in case of a non-synonymous genomic alterations, that could lead to the formation of a new antigen, and that new antigen can be recognized by the immune system, which can elicit an immune response. Now, to take care of the optimal immune response to be generated, T cell has inhibitory molecules called PD1, CTLA4, which are leveraged by cancer cells and by having PDL1 as a receptor. Now, the interaction between PDL1 and PD1 could send a turn off signal to the T cell, and hence T cell would become inactive. But if in case for these patients, immune checkpoint inhibitor therapy is used, which would block the interaction between PDL1 and PD1, in turn implying that T cell could now function at its full potential and can kill the cancer cells. So overall, high TMB is a predictive marker for immune checkpoint inhibitors therapy. FDA has approved following immune checkpoint inhibitors along with their clinical indications. Next, we have a marker called homologous recombination deficiency. In a normal cell, DNA double strand break repair is often taken care by two mechanisms. One is homologous recombination, which is a high fidelity and a standard conventional pathway if in case a double strand break repair occurs. But if in case this pathway is absent or the cell cannot is incapable of using this pathway, the cell is finally forced to perform double strand break repair using the non-homologous end joining, which is a error prone pathway. So homologous recombination deficiency is actually a phenotype which is characterized by the inability of a cell to effectively repair double strand breaks using the homologous recombination repair pathway. Clinical relevance of HRD is that it is an FDA approved biomarker for ovarian cancer. The marker is prevalent across different cancer types in around 17%. For example, in breast cancer, pancreatic cancer, ovarian cancer, and prostate cancer. And it is a predictive and prognostic biomarker for platinum based chemotherapeutics and PARP inhibitors. So, what is the cause of HRD, homologous recombination deficiency? This pathway includes around more than 30 genes, and the mutations in these genes could cause the homologous recombination deficiency. Of these 30 genes, the role of BRCA1 and 2 has been highly investigated, whereas the other genes also contribute to this phenotype, which in which is also known as BRCAness. And when a cell has this phenotype, it would like to go to the alternative mechanism for repairing double strand breaks called non-homologous end joining. Since because this pathway is highly error prone, it could lead to genomic instability, which is often measured in terms of three parameters called LOH, loss of heterozygosity, LST, and TAI. And the compilation or the sum of these three parameters is known as genomic instability score. So to interpret HRD, it could either be the evidence of cause or it could either be evidence of consequence, which would confer HRD positive. For example, in this table, either the presence of germline BRCA mutation or a somatic BRCA mutation or mutation in non-BRCA genes or the genomic instability score of greater than 42 would confer HRD positivity. Now, this phenomena of HRD homologous recombination deficiency is not prevalent across all cancers. It is mostly prevalent across ovarian cancers. But if in case we talk about the colorectal cancer, the rate of homologous recombination deficiency is only less than 5%. So these DNA repair defects could vary according to the cancer type because in colorectal cancer, the MMR deficiency is more prevalent, which is now the third multi-marker approach that we are going to talk about. This MMR deficiency is actually a repair pathway wherein if a mismatch occurs, the DNA strand is slightly distorted and these repair defects is taken care by the mismatch repair pathway. The four main proteins that are involved in this pathway are MLH1, MSH2, PMS2, and MSH6. And in case of this deficiency, it leads to a hypermutable phenotype called microsatellite instability. And since these mutations keep on accumulating, it leads to high TMBA. And finally, these patients qualify for immune checkpoint inhibitors. Now, having said about all the genomic testing, the guidelines, and the multi marker approach that we have, the overall message is to finally look at the actionable alterations from a pool of number of variants, which is now possible with the guidelines that we have for interpreting the sequencing variants by and coming up with the actionable insights for these patients. And not just that, we can now have NGS informed treatment decisions, which can have a profound impact on the survival of the patients because the patients that get the NGS testing will have higher probability of receiving the matched therapies and have shown the better survival rate, which is measured in terms of PFS and OFS, contrary to the patients who do not receive NGS testing. Thank you and have a nice day.